Welcome to this presentation on red blood cell anemic disorders. In this session, we'll explore what anemia is, how it's classified, and the different types you need to understand as a student or healthcare professional. Whether you're reviewing for exams or deepening your clinical understanding, this guide will give you a clear and memorable foundation. Let's begin by understanding what anemia really means and why it's so important. Anemia is a condition marked by a reduction in red blood cells or hemoglobin, resulting in decreased oxygen carrying capacity of the blood. Anemias can be broadly classified based on cause: blood loss, decreased production, or increased destruction of red blood cells. In this case-based session, we'll differentiate between acute and chronic blood loss anemia using two patients with very different presentations. Patient A is a young male involved in a motor vehicle accident with signs of internal bleeding and early anemia. Patient B presents with insidious symptoms. Investigations reveal iron deficiency anemia due to chronic GI bleeding. Let's compare the two. Patient A's acute blood loss leads to hemodynamic instability with normocytic anemia, while patient B's chronic bleeding causes microcytic, iron deficiency anemia. Acute and chronic blood loss anemia may both present with low hemoglobin, but timing, clinical signs, and lab results help us distinguish them. When the bone marrow fails to produce enough red blood cells, we call this decreased RBC production anemia. This is not due to bleeding or destruction of cells, but a failure to create new ones. There are three major categories of decreased production. First, we have nutritional deficiencies, such as a lack of iron, vitamin B12, or folate. These are essential for making hemoglobin and DNA. Without them, red cell production is reduced or ineffective. Iron deficiency is the most common cause of decreased RBC production. Think microcytosis and chronic bleeding. B12 deficiency causes macrocytic anemia and neurologic symptoms. Look for hypersegmented neutrophils. Folate deficiency mimics B12 deficiency but without neurological involvement, common in alcoholics and malnourished patients. Second, we see bone marrow disorders, where the bone marrow itself is damaged or replaced. This includes conditions like aplastic anemia, myelofibrosis anemia, or suppression from chemotherapy or radiation. When marrow shuts down completely, it's not just anemia, you'll see pancytopenia. Aplastic anemia is classic for this. Marrow can be replaced by tumors or fibrosis, resulting in myelofibrosis anemia. Look for immature cells in the blood. PRCA presents as isolated anemia with no other cytopenias. Causes include thymoma, autoimmune disease, and parvovirus. Chronic inflammation blocks iron release and blunts EPO response. This causes a normocytic or sometimes microcytic anemia. Third, are systemic and hormonal causes, such as chronic kidney disease, where there's not enough erythropoietin, or chronic inflammation, which blocks iron use and suppresses red cell production. Kidneys produce EPO, the hormone that stimulates RBC production. Without it, even a healthy marrow slows down. Anemia is a common finding in patients with hypothyroidism, and it's often normocytic or macrocytic in nature. Thyroid hormones play a key role in stimulating erythropoiesis. They help the kidneys produce erythropoietin and support red cell production in the bone marrow. In hypothyroidism, this stimulation is reduced. There may also be associated nutrient deficiencies, such as vitamin B12, folate, or iron, particularly in autoimmune thyroid diseases like Hashimoto's thyroiditis. The result: reduced RBC production, low reticulocyte counts, and often fatigue that's wrongly attributed only to thyroid dysfunction. So, always consider anemia as a contributing factor in hypothyroid patients who remain tired despite adequate hormone replacement. Chronic liver disease often leads to anemia, but not from a single cause, rather, it's multifactorial. First, the liver is essential for processing nutrients like folate and vitamin B12, and when liver function declines, macrocytic anemia can develop. Second, alcohol toxicity directly suppresses bone marrow function, reducing red cell production. Third, in portal hypertension, the spleen enlarges and begins to sequester and destroy red blood cells and platelets, a condition known as hypersplenism. And finally, patients with liver disease often suffer from chronic gastrointestinal bleeding, such as from esophageal varices, which contributes to iron deficiency over time. So remember, in liver disease, anemia is usually macrocytic, often accompanied by thrombocytopenia, and driven by a combination of nutritional, toxic, hematologic, and bleeding factors. In the next video, we'll shift our focus to a very different type of anemia, hemolytic anemia. Unlike anemias caused by decreased production, hemolytic anemias occur when red blood cells are destroyed too quickly, either in the blood vessels or in the spleen. We'll explore the causes, mechanisms, and clinical clues that help us recognize when the body is breaking down red cells faster than it can replace them. Stay tuned to learn how to differentiate intravascular from extravascular hemolysis and what lab markers to look out for.